Hello, my name is Nina Shake. I'm a Maryville University DNP student, and today it's my pleasure to talk to you about achieving safe intra-hospital transport of non-ICU patients by non-licensed transport staff utilizing a nurse-initiated standardized handoff form. I have had the honor to be able to work with Dr. Joanne Kern as my Maryville University chair. Dr. Kern has provided me with invaluable feedback, knowledge base, suggestions, and just her desire to help me to be successful has been something that has truly inspired me. According to the American Hospital Association, the United States has 924,000 staffed hospital beds. Each patient admitted to these beds have the potential to be transported to and from procedures and tests. With every transport, the care of the patient is handed off to another person. And it's during these times, these critical handoffs, that patients are at a higher risk for adverse and sentinel events as well as near misses. The Joint Commission states that too often patients who are being handed off for transports, medical procedures, or services, they can encounter problems with communication, which can contribute to patient safety. The Joint Commission has found that communication at handoff is so important that in 2007, they implemented a national patient safety goal for hospitals to follow. This goal was put into place because of the inadequate communication that they found to cause a lot of these sentinel events. Approximately 80% of healthcare errors occur during care transfer and the miscommunication in patient handoff. Most of the reported adverse events that negatively affect patient outcomes are from lack of communication and not from the skills or competencies of nurses or providers. Currently, I'm the Director of Clinical Services at the Study Hospital. One of the teams that I am over is the transportation team. I really got involved and interested in this study topic because the transporters would come to me with concerns over patients that they were transporting without a nurse. Some examples of these were nurses were stopping blood transfusions because they didn't want to transport the patient. Transporters were sent alone on runs with a patient that had newly inserted chest tubes or G tubes. The chest tube came out and the patient went into respiratory distress. My transporters were there with this patient who couldn't breathe. They had no idea what to do for the patient, and when they called for help, people were coming to help, but the transporter couldn't give them the information that they needed. Other examples were patients that were on high flow oxygen. Nurses were not helping the transporter transport, so these patients were having difficulty breathing, respiratory distress, and they're with an unlicensed transporter in a hallway or in an elevator. This really concerned me, and so that's really what got me started on doing research and wanting to do something to make a change to help decrease these patient safety events. Lack of handoff communication can cause adverse events throughout the country and in the study hospital. Some examples of these are, for instance, IV lines, tubes, and drains can be pulled out or discontinued, and a transporter would have no idea of what to do in a situation like this if it were to occur. Patient identification errors have been shown where if a nurse were involved in the handoff from the very beginning, they could ensure that the correct patient is going to the correct procedure. We also have to think about the scope of practice of the non-licensed staff. They are transporting a patient. The care of this patient is in their hands, and sometimes they're asked to be making decisions that's beyond their scope. Monitoring. Patients need to be on heart monitors, SpO2 monitoring, and if a transporter has not been trained in that, they're not going to get that monitoring. Equipment like IV pumps and chest tubes could be alarming. There could be issues with those. And if a transporter is alone and doesn't have a correct handoff, they will not know how to take care of patients. And all of these things can cause adverse safety events. The purpose of this study is to determine if the use of a nurse-initiated, standardized handoff form for intra-hospital transports of non-ICU patients by non-licensed transporters increase patient safety compared to transports where a standardized handoff form is not utilized. With being the leader of the transportation team, I reviewed policies that had to do with intra-hospital transport. I did find a policy that existed requiring the use of a ticket to ride with all intra-hospital transports. What I found out was that employees and transporters were not following this policy. There were numerous incident reports that were related to intra-hospital transport. When I would question employees and when I would question nursing or radiology staff and I would ask about the ticket to ride, I was told, I don't know what the ticket to ride is. I've never been made to use the ticket to ride. I've never been educated on the ticket to ride. And when the ticket to ride would print up and I would ask where it's at, I was told it was just thrown away. So this project, I really wanted to focus on improvement, quality improvement project to have nursing as the driving force of transportation handoffs. When nurses change shifts, they give reports to the oncoming shift or offgoing shift. This is important exchange of information, but this just was not happening with transports. We have unlicensed staff who are taking over the care of patients, but have no idea about the patient or what's going on with them. So to make this happen, I did a retrospective review of incident reports before an education intervention was given to staff, and then 6 months after the education intervention was given to see if that intervention did cause a decrease in patient safety events related to transportation. An extensive literature review was performed to make sure that there was evidence out there to help guide this study. A review of usage and non-usage of standardized handoff form and how it affects patient safety was looked at. The search was in CINAHL, Medline, PubMed, Google Scholar databases, and they actually assisted in finding several peer-reviewed research articles from 2009 to 2019. The search in these databases looked at effective communication at handoff, barriers related to handoff, any kind of patient safety and adverse events that were studied during intra-hospital transports, and the use of a standardized handoff form. The search resulted in 329 articles. These articles were reviewed to ensure their significance to the study and were grouped into 3 different themes utilizing 10 main articles. There were 3 main themes identified in the literature review. The first theme was patient safety during intra-hospital transports, specifically transports that were non-ICU. These were patients that were being transported by a transporter alone, and that occurred with med-surg type patients and some ER patients. The literature found that there were several categories of patient safety incidents: communication, IV lines, equipment issues, medication errors, those type of things. The second theme were barriers to effective handoffs. In the literature, it was found that nurses seemed to have barriers on why they couldn't give a handoff. Either they were too busy, either they didn't know that they were supposed to, they thought that they would give handoffs at shift change, but that wasn't required for transport. Other articles found were based on themes of utilizing a standardized report for handoffs. Some units had these for change of shift report, but there were also times where these were shown that they were needed and benefited with transportation type handoffs. Every study should have a theoretical framework that helps guide the research. For this study, Lewin's change theory, or Lewin's force field analysis, was chosen. Lewin's change theory supposes that there are forces at work when it comes to change. These forces are either driving or restraining. The driving forces move to promote a person towards making the desired change, while the restraining forces move or inhibit a person away from the desired change. There are 3 distinct stages in this theory: unfreeze, moving or changing, and refreeze. So in this slide, it is demonstrated that there are driving forces for people to use the standardized ticket to ride form: patient safety, decrease in adverse safety events, improved communication, and just restructuring the transport process in general. While the restraining forces are staff say, I'm too busy to review the ticket to ride with the transporter, or it's not my job, or just lack of effective communication, or really a lack of staff accountability to follow the policy. The methodology chosen for this scholarly project was a retrospective chart review. Data from patient safety incidents that were related to transportation and were reported in the MIDAS system were reviewed 6 months before and 6 months after an education intervention was provided to all staff. Participants were not engaged in any way. No patient information was abstracted from the incident reports, and all patient identifiers were removed and were not collected for this project. This was to maintain patient privacy and to follow HIPAA guidelines. The study hospital has an incident reporting system called MIDAS. So the data for this study was extracted from this incident report system. Patients included pediatric and adult patients that were admitted as an inpatient or was a patient in the emergency room, anywhere from ages 1 to 99. Patients had to be transported to a test or procedure by a member of the transportation team and had to be involved in a reported patient safety event to be included in the study. A data collection instrument was created for this study. A separate collection sheet was used for pre-intervention data and post-intervention data. As the incident reports related to transport were reviewed, a 1 for yes and 2 for no were placed into the appropriate category from the MIDAS events. The numbers from each category were added on both the pre and post data collection sheets. This numerical data was then placed into the specific test to help determine if there was significance in the interventions. The intervention in this study was an education that was given to all staff who have anything to do with intra-hospital transport or who utilize the transportation team. This was a mandatory e-learning that was put onto every staff member's e-learning plan. The objectives of the education was to review transportation partner job description, to introduce updated transportation guidelines, and to reinforce correct ticket-to-ride process and the reasons for utilizing it. Information was given, and then a post-test was also in the e-learning. Staff had to pass the post-test to be able to pass the course. This was required of all staff. Inferential and descriptive statistics were used in the data analysis plan for this study. Z-test for the difference of two proportions was used to analyze the data. The z-test for two proportions is used when you want to know whether two populations or groups, in this study, pre-intervention group of MIDAS reports or post-intervention group of MIDAS reports, differ significantly on some single characteristic. In this instance, the characteristic would be whether the education was given or not. Also, a lower tail test and p-value was calculated at a 95% confidence level. Descriptive statistics were used via graphs and tables to show and demonstrate the data that was collected and the results that were obtained. This table shows the research study results. Group 1 is pre-intervention, Group 2 is post-intervention. The sample size for Group 1 and 2 are very similar. Both had over 17,000 transports that were performed by transporters in a 6-month period. Group 1 shows that there were 62 patient safety events that were reported in the MIDAS system, whereas Group 2 post-intervention shows that there were only 17. The confidence level was calculated at 95% and the p-value was found to be 0.00 with a z-value of negative 1.6449. These both show that the intervention did decrease the number of reported safety events, and they were statistically significant results. These two graphs help to demonstrate the findings from the study. The graph on the left are the pre-intervention number of reported safety events from each unit. Units that were studied that had reported patient safety events were med-surg, progressive care, maternity, pediatrics, ER, and ICU. The graph on the right also shows reported events from med-surg, progressive care, maternity, pediatrics, ER, and ICU. As you can see from these, there was definitely a decrease and the number of reported patient safety events pre-intervention versus post-intervention for all of the units that were studied. This graph also helps to demonstrate the findings of the results. Each category, IV lines or tubes, communication issues, oxygen issues, medication issues, equipment issues, and was a ticket to ride form used, are shown. This is a side-by-side comparison also of the number of pre-intervention safety events versus post-intervention safety events. You can see in each one of these categories there was a decrease as well. And also there was use of the ticket to ride form used, as you can see in this graph. One significant and very important finding that I like to highlight from this study is the utilization of the ticket to ride form. As mentioned before, the ticket to ride was in the policy and was required by staff to use, but nobody was using it. So 6 months pre-intervention, the ticket to ride form was found that it was never utilized with transports. 6 months after the intervention was given, the ticket to ride form was used with every transport. This is really important because it stresses how the ticket to ride can decrease patient safety events, but also that staff were held accountable by managers, directors, and executive leadership. The education, which was the intervention for this project, was required by all staff to take. This was part of their mandatory e-learning. So it really makes me feel good that I am in an organization that supports patient safety. Patient safety events related to IV lines or tubes decreased by 50%. Examples of these would be if a patient had an IV line that was dislodged, a chest tube that was kinked or dislodged, or possibly a G tube that was kinked or dislodged. Patient safety events related to communication issues decreased by 67%. Some examples of this would be if a nurse then would communicate to a transporter that a patient was in a lot of pain in their arm or leg, or communication that a patient was a high fall risk, or that a patient had a medication that may make them sleepy or drowsy. These are the type of issues that would be in the handoff. Patient safety events related to oxygen issues decreased by 100%. Some of these issues were around oxygen tanks not being filled properly and going empty during transport, high flow oxygens being transported by transporters alone. Patient safety events related to medication issues decreased by 83%. Some of the issues in this area were patients being transported by transporters that were on drips that required nursing intervention or monitoring. Patient safety events related to equipment issues decreased by 74%. This was also very significant. The only perceived limitation of this study are safety events related to transport that were not reported by staff. If a safety event related to inter-hospital transport occurred and was not reported in the MIDAS incident reporting system, it was not included in the study. So this would include incidents that were reported verbally to managers, directors, or the risk manager. Anything that was reported via email would not have been in the study as well. It's really important to understand at the hospital study site that transporters do not have a license. They are not nurses. So when a patient is transported by a transporter, they are not under the care of their primary nurse. Utilizing a nurse-initiated standardized handoff form, similar to the one in this study, can help relay important patient safety information and keep patients from experiencing a negative outcome related to transport. An example, if a patient were being transported and they were caught in the elevator or a hallway and something were to happen and a transporter were to get help, the people that are helping have to know the patient's situation. They need to know what's going on with the patient. So that's another good reason to have this standardized handoff form with the transporter so they can relay that information. I'm very hopeful that this study will be a reference for future studies focusing on safe intra-hospital transport of non-ICU patients and the use of nurse-initiated standardized handoff form. The results from this study were statistically significant to show that standardized handoff forms that are initiated by nurses can definitely decrease patient safety incidents related to transport. By using the same methodology and study design, future researchers can reproduce this study and have similar study results at their place of study.